So welcome to our Global Network webinars. My name is Alexander Loschke, and I will be moderating this webinar today together with my colleague Yushi Sang. So before we start with the usual introduction, we will first show you a short video.
Numbers matter. Timely, reliable, comparable, disaggregated, and actionable data are critical for measuring and tracking population health outcome, their determinants, and health inequality therein. With these, information is the basis of better targeted health planning at every level and helps decision makers develop and implement equity-oriented policies and allocate resources more effectively. COVID-19 has illustrated how urgent the need for such data is for guiding swift response to the pandemic and drive strategic policy changes. Every year, the World Health Organization consolidates the latest data on health-related indicators through the World Health Statistics Report, a flagship product that brings together a consistent set of data as a trusted source of global health statistics and trends. The data in this year's report not only highlighted the troubling pandemic we are currently in, but also confirmed some progress made in improving population health outcomes, addressing major health risks, scaling up universal health coverage, and strengthening health information systems. However, the progress is not fast enough, or completely lacking for some indicators, and persisting inequality further threatens achieving the Sustainable Development Goals and triple billion targets. Immunization, anemia in women, hepatitis B, child malnutrition, global health security, air pollution, hypertension, insufficient physical activity, universal health coverage, health workers' density, water sanitation and hygiene, obesity, access to health technologies, intimate partner violence. Critical data gaps remain, and countries and WHO will continue to strive to improve data availability, data quality, and levels of data disaggregation. Download the latest edition of the World Health Statistics Report for country, regional, and global data.
So this was a short video presenting, giving you an introduction to our topic today. So we will have today 4 colleagues from the World Health Organization presenting to us. So we will have Samira, Asma, William Msemburi, Bochen Jiao, and Nelly Biondi, who will present the World Health Statistics Report 2020. And we are extremely happy to have them all with us today. The World Health Statistics Report is an annual assessment of the state of the world's health, with the latest data on more than 50 health-related indicators from the UN Sustainable Development Goals and from the WHO triple billion targets. The 2021 edition was published in May and presents the latest data and trends for life expectancy, mortality, and burden of disease at global and regional levels. It also includes preliminary estimates for the global excess deaths that are attributable to COVID-19 in the year 2020, with a focus on health inequalities and data gaps that have been accentuated by the pandemic. So in this Global Network webinar, our speakers will explore the stories behind the data and will highlight the key findings. So let me now introduce our speakers. We have with us Samira, who is the Assistant Director General for Data Analytics and Delivery for Impact at the World Health Organization, where she leads the efforts to use timely, reliable, and actionable data to drive progress towards the triple billion targets and the health-related sustainable development goals. Prior to joining the WHO, Samira served for many years in leadership positions at the US Centers for Disease Control and Prevention, or better known here in the US as the CDC. William is a statistician and demographer, and he's leading the work on global access mortality estimates attributable to COVID-19. Bochen is demographer and epidemiologist and is responsible for population health metrics, including mortality, morbidity, and burden of diseases. And Nelly is a data analyst, and she focuses on measuring and tracking progress in coverage of essential health services as part of universal health coverage. Before I hand over to Samira, let me just mention a couple of things like usual. So we will first hear the presentations and we'll then have the Q&A session at the end. Please feel free to write your questions into the meeting chat at any time so we can have a look at them. And during the Q&A session, we can either ask the questions for you, or you can raise your hand in Teams and then ask your question yourself. As always, this Global Network webinar is being recorded and will be made available on the Global Network of Data Officers and Statisticians at yammer.com/UNstats. And we invite you to continue the discussions on the Global Network after the webinar. So now over to you, Samira. Samira, the floor is yours.
Thank you very much, Alex, and colleagues. Good day to you, and thank you for taking time from your valuable schedules to listen to the updates from the World Health Organization. So greetings, and I'm joined by my colleagues, including the three speakers, but I also have Diane Esteves, who has led the coordination of the report also with us. I will begin with a quote of Dr. Tedros, who said that we cannot make progress if we cannot measure progress. So when WHO embarked on its transformation journey, when Dr. Tedros, our Director General, took office, accountability supported by data was the fundamental pillar to the 5-year strategy called the General Program of Work. Built again, if we can't measure, we cannot manage. And health, as you know very well, is central to the Sustainable Development Goals. And COVID has really accentuated how health is so indivisible across all the 17 goals. It is associated very closely with economics and development. If we cannot recover from COVID, we cannot recover from the economic crisis either. So very much interlinked. And your ideas and your questions and feedback is going to be very important to us as we conclude this session. COVID has really brought to focus the need for timely, reliable, disaggregated, accessible data. And we also have realized, sadly, that the world was not prepared to deal with this pandemic. Epidemics become pandemic. And if we have timely data, similar to how the weather is forecasted, because we have tools at our disposal. What is missing? Why did not we were prepared? There are many factors, and one underlying factor is lack of timely information. It has been very clear we cannot even count deaths due to COVID accurately, even in the most developed countries. We are relying on guesstimates and reports, etc. This is very fundamental that every country should have a robust civil registration and vital statistics. that also influences a number of SDGs, from births to deaths, and more importantly, causes of deaths. So statistics plays a very central role for us to be better prepared for the next emergency crisis as well. WHO's 3 primary pillars are to have at least 1 billion more people enjoying better health by 2023, but now it is 2025. We'll come to that. Another 1 billion more people having access to universal health coverage without financial hardship. I see that there are many economists besides statisticians who have joined us today. So this is of interest to you. And the third priority is to have at least 1 billion more people protected from health emergencies. These were the targets that had been set in 2018 for the next 5 years. And then pandemic happened last year. We have continued, and now we have become more active in pursuing these triple billion targets, because we see these as a road to accelerate progress towards the 2030 agenda. The billion is a way to count to ensure we don't leave anyone behind. We respond to member states like any other UN agency. The member states have requested 3 things from WHO, and we can't do it alone. And that's where statistics, technology, economists all come into play here. One is recognizing there are significant data gaps and data capacity, statistical capacity is missing, or there are gaps in many countries. So the member states requested WHO to support, strengthen their data and health information system capacity. The second is there is a lot of fragmentation across the world as well as within WHO and across the UN organizations. To bring all data under one umbrella, guided by proper data governance framework to make data available so that countries can access it and track the progress or lack of. And finally, third is the most important one, is to use data to drive progress and to be accountable. So this is mainly an accountable framework. World Health Statistics Report is an annual health checkup of the population. And we have done a relatively okay job in reporting the latest statistics across 50 plus health related SDGs. There are altogether 56 health related SDGs, and they all rely on data systems such as administrative, surveillance, census. Many data systems should bring to bear our report to define the progress towards SDGs. So you will hear more about how far we have come along in reporting progress towards the SDGs and where we have stalled behind. COVID has definitely put us back on track, put us off from the track. So only having good systems to track, we would be able to make progress. So this is not only a global report, but it provides a country specific and regional specific overview across all the indicators and the triple billion targets. We were also able to review the excess deaths, which is a very important development in the report. And you will hear more as to what the formal and official report on deaths are and what the excess deaths have demonstrated and highlighted. So what do we do about the data gaps? We have institutionalized a score for health data technical package. We have done the first ever assessment of countries' data capacity and systems to track health profiles of every country, from data collection to data use. And what we found is that 4 out of 10 deaths, only 4 out of 10 deaths are registered. And this becomes more serious when we look at it from the African regional lens. 9 out of 10 deaths go unreported. Only 27% of the countries are capable to track health threats, population health threats through surveillance systems. So these are very serious gaps that we have. And we have to rely, of course, on estimates, but often we are stumbling because we are guesstimating and we can't even have good mechanisms to do the supply chains of medicine, diagnostics, etc., to the populations that are in need. So data becomes again extremely important. You are here for a treat to learn the findings of the World Health Statistics Report, and we very much look forward to working with you because multi-sectoral partnership is going to be extremely important to bridge all the various streams of data where we can really put together the landscape of health data as we move towards the 2030 agenda. So with that, I will pass on to my colleagues to walk you through in depth about the report. Over to you, Alex. Thank you.
Thank you so much, Samira, for this introduction and for pointing out how important data is, not to tackle only this challenge with the current COVID-19 pandemic, but also in general to keep track of the development of countries and also of the people living in all countries. So I will hand over now to your colleagues. Please go ahead and start with the presentation.
Good morning, good afternoon, everyone. I'm Bochen from WHO. So please let me start with a brief introduction of the World Health Statistical Report. The World Health Statistical Report is WHO's annual compilation of the most recent available data on health and health-related indicators for its 194 member states. It presents data on the current state as well as the historical trends for 49 SDG health-related indicators and 4 additional indicators under WHO's 13th General Program of Work, as well as some overarching health indicators, including health life expectancy and healthy life expectancy. This report is spearheaded by the WHO Division of Data Analytics and Delivery for Impact, in collaboration with 29 technical units spanning across 8 divisions within the WHO headquarters and the regional offices. So it's truly an organization-wide effort. And now my colleagues Nelly, William, and myself would like to present some key findings and learnings from this report. Next slide, please. One of the main findings throughout the report is that prior to the COVID-19 pandemic, many improvements in health were made. However, the progress is not adequate for attaining the health-related SDGs by 2030. The global population continues to live longer and live more years in good health. Between 2000 and 2019, global life expectancy at birth increased from about 67 years in 2000 to 73 years in 2019. And healthy life expectancy increased from 58 years to about 64 years. Yet, there has been some persistent inequalities. Life expectancies and healthy life expectancies among females were consistently higher than males, and life expectancies and healthy life expectancy also rise with national income levels. However, as we observed, the greatest improvements were observed in low-income countries. These countries have gained over 11 years in life expectancy and nearly 10 years in healthy life expectancy between 2000 and 2019. This predominantly reflects the remarkable progress made in reducing mortality among children under 5 years of age. These patterns were also driven by the rapid transitions in the evolution of mortality and morbidity profiles since 2000. The dramatic decline in premature mortality due to communicable diseases, particularly in those low-resource settings, has shifted the disease burden to non-communicable diseases. As a result, the global share of NCD deaths among all deaths increased from 61% in 2000 to about 74% in 2019. And in high-income countries especially, NCD is now accounted for up to over 85% of deaths. Among them, the leading ones are heart diseases, dementias, and strokes. In contrast, in low-income countries, communicable diseases were still responsible for nearly half of all deaths, with lower respiratory infections, diarrhea, malaria, HIV, and TB remaining in the top 10 causes of death. The vast majority of the incidences and deaths of communicable diseases occurred in low-income countries and lower middle-income countries. So these diseases, the major contributors are TB, HIV, malaria, neglected tropical diseases, and hepatitis B. Despite the overall decline in mortality, a comparable improvement in morbidity was absent, and in fact got worse to some extent because of this decreased fatality of many health conditions. Globally, the age standardized average of years lived with disability per capita remained at approximately 0.15 years throughout the last 20 years period. This largely reflects the stagnation of disability due to NCDs and injuries. Although the age standardized rates of morbidity due to communicable diseases has declined by about 11%. Next slide, please. Now let's take a closer look at the trends in the past 2 decades by individual diseases and injuries. And as we see, there have been some steady decline in many types of communicable diseases. The annual number of TB incidents and deaths globally have fallen by about 25% and 45% respectively. And new annual HIV infections have been reduced by 40% since the peak in 1998, and the HIV-related deaths have fallen by over 60% since its peak in 2004. Similar downward trends were also observed for malaria. And in terms of NCD, the world has also seen some progress since 2000. However, the progress is not comparable to that made for curbing the communicable diseases, and the progress is unequal across regions and income groups. Among the 4 major NCDs, namely cardiovascular diseases, cancer, chronic respiratory diseases, and diabetes, the greatest decline in mortality was seen for chronic respiratory diseases in terms of the age standardized rates across all age. And this is followed by cardiovascular diseases and cancer. However, diabetes has shown some unfavorable trend with slightly increase in age standardized rates of death. Although the overall trends in mortality for the 4 major NCDs are heading downwards, as indicated by the age standardized rates, the absolute numbers of deaths attributed to these causes have actually gone up. This is largely due to population growth and population aging. Specifically, the total global deaths from cardiovascular diseases grew by 1/4 since 2000 and reached almost 18 million deaths in 2019. Cancer deaths grew by over 35% to now 9 million, and chronic respiratory diseases grow by over 10% to 4 million, and diabetes by over 72%. And that's the largest relative increase among all of the major NCDs. And when it comes to injury, more than 4 million people died because of injuries in 2019. This is equivalent to 8% of total global deaths. Whether it's intentional or unintentional, these injury deaths can be largely prevented. Deaths from the 4 specific types of injuries that are addressed by the SDGs, namely homicide, road injury, suicide, and unintentional poisoning. We have seen downward trends for these 4 injuries in general from 2000 to 2019. And also overall, men face much higher risks of death than women for these types of injuries. For example, 80% of homicide deaths from homicide were men, and men were also dying from poisoning at a rate that's nearly 70% higher than women, and dying from suicide at a rate that doubles the rate of women. In summary, despite the progress already made, the current pace of improvement is not rapid enough for many of the indicators to meet the SDG targets by 2030. And those include premature mortality from NCDs, the incidence of TB and malaria, the new HIV infections. These challenges underscore the need for a strong disease and injury prevention and control program to adequately accelerate the current progress for meeting various national and international health targets. One of the best bets would include investment in health promotion, multi-sectoral interventions to reduce the exposure to risk factors, and also to improve diagnosis, treatment, rehabilitation, and palliation with strengthened health systems. Next slide, please. And in the report, we also show the underlying risk factors that have shaped the burden of diseases, as we showed just a few minutes before. And the progress in reducing the exposure of risk factors is mixed and also manifests inequalities as well. As we can see in the report, overall, there has been a reduction in harmful risks to health, including child stunting, tobacco use, air pollution, and hypertension. However, there has also been less progress in some health risks. For example, physical inactivity, harmful alcohol consumption, and the prevalence of anemia. And in fact, which is more worrying, is that there has been some increase in the prevalence of obesity, with up to a quarter of population in high-income countries now are being obese. And in terms of inequalities, the inequalities in the levels of these risk factors, and as well as the improvement made over the last 2 decades remains there are still inequalities between regions, between countries, and as well as within countries. So lower resource countries continue to be exposed to ambient and household air pollution at much higher rates than the more developed countries. Children and women in lower resource settings were also at higher risk of malnutrition conditions, including stunting, wasting, and anemia during pregnancy. These inequalities inevitably hinder the progress towards minimizing the exposure to such risk factors, because the most vulnerable populations not only tend to be exposed at much higher rates to these health risks, but they are also less likely to have access and to benefit from effective health interventions. So the lesson learned from these findings are we need to accelerate the progress. All these factors account for a considerable fraction of burden of diseases and results in premature and preventable deaths. Addressing these health factors are one of the priorities of the SDG health-related targets, and as well as the WHO triple billion targets. Only through multi-sectoral policies and action plans that we can accelerate progress in achieving these targets in a reasonable short period. And the other lesson we learned is in the backdrop of the COVID-19 pandemic, we've seen evidence that the pandemic has already reversed some of the progress and worsened the existing health inequalities. Additionally, people with NCDs and other associated underlying risk factors have been reported to be at higher risk of severe illness and death since the pandemic began in last year. And as such, it becomes more important that multi-sectoral actions be strengthened at global, regional, and national levels to mitigate the impact of COVID-19 and put the progress back on track. And now I would like to hand over to my colleague Nelly for her presentation on universal health coverage.
Thanks, Bochen. So, as you know, UHC is defined as all people receiving the health services they need, whatever the type of health services, of sufficient quality to be effective, while at the same time ensuring that the use of these services does not expose the user to financial hardship. As things stand currently, there is an urgent need to strengthen health systems and remove remaining barriers to allow access to health care for all without financial hardship. As you can see on the graph on the left, although improvement in coverage of essential health services were recorded in all income groups and also across different types of services between 2000 and 2017, the pace of progress has slowed since 2010, and the poorest countries as well as countries affected by conflict generally lag further behind. The COVID-19 pandemic poses substantive challenges to health systems globally, balancing additional service delivery needs required to manage the pandemic, while preserving and enhancing access to essential health services. And this is particularly challenging for countries with weaker health systems. What the graph on the right tells you as well is that overall financial protection against out-of-pocket health spending prior to COVID-19 was deteriorating. The impact of COVID-19 on household health spending remains uncertain, as there is evidence of income shrinking, poverty increasing, and households foregoing health care. Next slide. So the pandemic also further impacts the availability and capacity of health workers to deliver essential services and meet surge needs. Health workers are both a central component of the pandemic response and among those most vulnerable to infection and mental health impacts due to their professional exposure. As you can see on the graph, and this is just an example looking at physicians, there are dramatic disparities in health workers' densities across WHO regions. And even when national densities are sizable, inequalities persist between rural, remote, and hard-to-reach areas compared to capital cities and urban cities. The third point is that regionally, health workers who deliver essential services are at their lowest density in the places where the highest burden of disease are measured. In other words, low staffing levels are associated with the spread of pathogens in healthcare settings and risk of outbreaks. So what are the learnings Continued progress on universal health coverage is needed to mitigate the worst effect of COVID-19. It required considerable strengthening of health system, particularly in lower income settings, along with a recognition of the crucial role of healthcare workers in public health facilities, with adequate protection for their safety and well-being. Next slide. So the graph on the right illustrates what would be the progress towards reaching the 3 billion targets if the world would continue on the same trend as in the past. This is without taking into account COVID-19 impact. And you can already see that there are shortfalls for each of the billion targets, particularly for UHC billion target with a huge shortfall of 710 million. So what does it mean? It means that the world was already off track to meet the SDGs and the WHO 3 billions, and COVID-19 has upended recent progress and increased inequalities. It is very important to monitor health inequality. It is absolutely essential, an essential step to achieve health equity and leave no one behind. Every country deserves a strong health information system that can inform policies to save lives and allow people to live a healthier life without the burden of excessive healthcare costs. So now I'm going to give the floor to my colleague William, who will talk about the COVID-19 impact on population health. Thank you.
Thank you, Nelly. Thank you, Bochen. Thank you, Samira, and good day to everyone. So I am talking about the impact of COVID-19 on population health, which is one of the we looked at this in the report, and it's obviously of significant importance as we move forward. So first of all, looking at what is known about the burden, so the reported burden of COVID-19, I know that there have been over 153 million confirmed cases and over 3.2 million deaths that were reported to the WHO by the 1st of May 2021. Which is the time period that we looked at for the World Health Statistics report. In terms of the regional variation, the region for the Americas and European region were the most affected when we consider this reported burden. Together, these two regions comprise more than 3/4 of all the confirmed COVID-19 cases. In terms of the mortality burden and the deaths, 48%, so almost half of the COVID-19 deaths for the period 2020 up until May 2021 were for the region of the Americas and 33% for the Euro region. In terms of the World Bank income groupings, there's also variation across those aggregations. So the cases were concentrated in high income countries, which we just have there as HIC. So 20 of the most impacted high-income countries accounted for 45% of global cases, but these represent 12.4% of the global population. So what we tried to do within the report is really to show and highlight what are the regional distributions of COVID burden, and then what do you have in terms of the income group burdens. And this is for the reported data. If we can go to the next slide, please. Another aspect we looked at in the report was the disaggregation of the data that are available for COVID-19. And specifically, we looked at the case report forms that have been reported to WHO's health emergencies. So the case burden itself was found to be comparable between males and females, but the male deaths were slightly higher. So if you look at the plots on your right, far right, that's the plot of the COVID-19 deaths, probable and confirmed, broken down by sex, where your pink is a female, orange is your male, and we also have the age disaggregations there. And you can see that for the males, you have slightly more deaths that occurred, particularly as you go lower than the age 80 plus. You see that there's more males if you even highlighted there, the age 50 to 59. So these are the COVID-19 male deaths and cases as reported or recorded in WHO's case report forms. One of the challenges in looking at this are actually the gaps in the data. So the data are not of consistently good quality across countries or regions. And this is something emphasized in these bullet points where we're talking about data quality. 99.3% of the Afro data that came in was actually missing the sex attribute, right? And if we go further, you see that for the other regions, the region of the Americas, Eastern Mediterranean, if you look at Euro, Sierra, or even Wipro, they have lower proportions of that data that are actually missing this attribute. And the global average there is 8% of the data that were missing sex. Age was actually missing in more of the data. So 99.6% of the data coming in from the Afro region were missing the age attribute. And just over half of the data that came in from the region of the Americas was also missing that. However, you see that the data that are coming in from Wipro and AMRO, sorry, from Wipro, Sierra, EMRO, are of better quality, at least with more of the data actually having that attribute. So 44.2% of the data that we received were actually missing age. So the learning from this is that there's an opportunity here to improve the information that we're getting for COVID-19, both in terms of the quality of that information and the completeness of that information. It is necessary to get this the data on some of these attributes really to understand which populations are more at risk and to design policies of intervention that are appropriate based on the distribution of burden. So we have a learning there that we need to improve the data, the quality of the data, the disaggregation of the data, not only for COVID routine surveillance, but also to extending that, just strengthening health information systems in general and other existing routine surveillance systems. Now I'm going to focus on excess mortality. So in many locations, the reported number of COVID-19 deaths is a significant undercount of the full toll of the pandemic. As an example, there I'm showing the plot of Bulgaria deaths starting from February 2019, extending all the way to May 2021. The green, you have the expected number according to these time series methods. We just used a random walk there. The orange gives you the above the expected. If you add the reported COVID-19, what are the deaths that are quantified there? And then the black, those are the actual observed deaths for the time period which is referenced. And as you can see, the actual observed deaths are significantly higher than the sum of the expected plus the reported COVID, which means if you just looked at the sum of the expected and reported COVID, that gives you quite an undercount of the true toll of the pandemic. So when we talk of excess mortality, we're referring to the difference in the total number of deaths in this crisis-related period when we're comparing the expected, which is the green line, under non-pandemic conditions to what's been observed, which is the black line there. The strength of the excess mortality measure is that it includes the COVID-19 deaths that are correctly certified, those that are not reported. So these are COVID-19 deaths that are not reported or that have been misattributed to other causes. And then the excess mortality measure also accounts for the net effects of changes in other causes that are related to the pandemic or to responses. So you have the direct impact of COVID, but you also have these indirect knock-on effects that are accounted for in there. Now, to be able to estimate excess mortality, accurately for all countries of the world, including those with good data systems and those without. The WHO and UNDESA convened a expert technical advisory group, or TAG, to advise on methods and data for estimating excess mortality. And it's the inputs from the TAG that were reported in WHS. You can go to the next slide, please. So what I'm showing, this is reported in the World Health Statistics report, and it's in a data story that also came out around the World Health Assembly. And it's an output of the advice of the TAG looking at excess mortality for the year 2020. So following evaluation of Poisson type models, so the TAG advised to use Poisson type models to estimate the all-cause number of deaths for 2020, and based on those models and evaluating their performance, validating the results and the estimates coming from them, it was agreed to present the estimates for the region of the Americas and the European region, which are regions with much better quality data. So for the European region, we have data from 50 out of 53 countries. And for the region of the Americas, we had data out of 15 out of 35 countries to use in the modeling. Whereas for some of the other regions, we have less than half. And for the Afro region, for example, we only have data for 3 out of 47 countries. So we're not able to use those, and the model was not found to be robust as yet. So the estimated excess deaths for 2020 were found to be significantly higher than the reported COVID-19 deaths. So as you can see there in the plot on the right, for the region of the Americas, we're estimating excess deaths ranging from about 1.34 million to 1.46 million, contrasted against the reported 900,000 or 0.9 million COVID-19 deaths. Similarly, for the European region, excess deaths 1.1 to about 1.21 million, which is almost double the 600,000 reported COVID-19 deaths for that period. For the other regions, we ultimately used a tentative extrapolation of the ratio between excess and COVID and reported COVID from the regions above to scale the reported COVID deaths for the period and for that time. So there's about 360,000 reported COVID-19 deaths for that period when you aggregate the Southeast Asia, Eastern Mediterranean, African, and Western Pacific region. And we took the scaling factor or ratio of reported COVID to excess coming from AMRO and Euro and extrapolated that. And based on that extrapolation, we have a lower bound of 3 million excess deaths globally, which can be contrasted to the 1.8 reported COVID-19 deaths, again for that period. The TAG work is ongoing. So the work currently is to strengthen and extend the model so that we're able to predict excess mortality beyond the AMRO and Euro regions with country-specific scaling factors that are not based on extrapolation, but based on a model fit. So that's work that's ongoing, currently looking at the best predictors to do that, looking at strengthening the model itself, validating the model. And as I said, this is ongoing, and we're also looking at extending the analytic period from beyond 2020 now into 2021 to ensure that we can also capture some of the patterns that have been seen. If you consider what we've observed in Southeast Asia, the spike in Indian cases in India recently and in other low-income countries, we know that the 2021 profile will also have some differences to 2020, and we're actively looking at that to make sure that we're able to inform the world on those estimates. I believe that is the end, and we can go to some questions and feedback. Thank you.
Thank you so much to everybody. So we will now give everybody the opportunity to ask questions. So please let us know in the chat your questions, or you can also use the raise my hand function in Teams, and I will also now turn on the ability to unmute yourself, so you can also choose the opportunity to ask the question personally if you wish so. So let me maybe start by one question. I hope you can still hear me. I had just a black screen, but I will just continue talking. So let me have one question maybe about exactly the last thing that you were just presenting about the excess deaths attributable to, or probably attributable to COVID. And you were mentioning that estimates are only available for two regions, so basically for the European region and for the Americas. Can you also say maybe something about the number, the changes in the number of deaths recorded in some countries which have not a very good civil registration system? I think in some countries, probably the number of recorded deaths, total deaths in those countries actually went down due to the pandemic. Have you observed this in the data that you have received? And maybe you can say a couple of things about the causes of that. Thank you.
Sure. Yeah, that's a great question. We are aware that there are places where the historical mortality profile was strongly connected to contact and infectious disease, for example, based on influenza and influenza mortality. We're also aware that due to government interventions, things like lockdowns, that there was some reduced injury related mortality as well. And that is something that is an artifact even in the data that are available. So in the places that have current data, countries like Australia, you see that the mortality experience there is actually lower than expected, which means that deaths have been averted, or there's been a protective effect that's come about because of the pandemic. It is something that we're trying to include within the model. So the model looks at what is the excess, be it positive or negative, and can we connect that to a set of covariates? And again, that's ongoing, and as I say, it is part of the modeling framework. Over.
Thank you. Let me hand over to my colleague Yushi, who had a look at some of the questions which came in the registration form to today's event. Yushi, over to you.
Yeah, thanks, Alex. So far we have collected some of the questions from our registration form. So one of those is about, so will a global life expectancy will be impacted by the COVID-19 pandemic? Maybe you can say a couple of words on that.
Yeah, who wants to take this question?
Bochen, do you want to take it?
Yeah, I think, well, we have already seen some evidence from the United States, which have seen life expectancy dropped by over 1 year. And there are also evidence from, based on data from the Eurostat. In many of the European countries, we've also seen life expectancy dropped by 1 to 2 years in 2020. there are not enough data points for less developed country yet. And especially those countries in 2020 at least are less impacted by COVID-19. So in any case, in the high-income countries, which are impacted by COVID-19 in 2020, a decrease in life expectancy is anticipated. Thanks.
Okay. Thank you, Bochen. And yeah, I think that would be really reasonable, and due to the COVID-19 pandemic. And also during the same times, so far we can see there are a couple questions being asked in our meeting chat. So first of all, I can see Gerardo. Sorry if I pronounce her name incorrectly. So I'm not sure if you want to unmute yourself and ask the question yourself, or we can also read your question.
Gerardo, if you want to unmute, it's fine. If not, I can read the question for you. So Gerardo was asking what percentage of the data collected comes from verified death certificates, and do you take into account or do you collect data on primary, secondary, and tertiary causes of deaths?
Well, Grado, I don't know if you are asking this cause of death in general or asking for COVID specifically, but please let me start with the general cases. So for estimating the cause of death and its specific death rates in our report, we've used vital registration data from about 80 countries that with good completeness and also good coding practice. So there are fewer proportion of deaths that are miscoded. So for these countries, I think it's about 70, around 70 to 80 countries that we use death certificate, use VR data that's based on death certificate. And for other countries, the estimates are based on a variety of sources of data input. And for the VR countries, it usually only reports primary death. And I think if for the COVID-related death, I will redirect that to William.
For the COVID-related deaths, we are still looking in the future in terms of the multiple causes. You have a question about the multiple causes beyond the underlying cause of death. What is the secondary or tertiary cause of death? And one thing to note is we do not receive unit record data to be able to access that. Most of the data that we receive will be collated from death certificates, but aggregated across the underlying cause of death. I think we would have to do much more rigorous studies in country with unit record data to be able to look at, for each of the causal sequence on the death certificates, are we able to assess multiple causes? So that is something that we are looking at for the future, but to just take note, the data we receive is aggregated and not unit record. Over.
Thanks, William and Bochen. There was another question by a colleague from UNICEF, Rary Venice. I'm not sure if you want to ask the question yourself. If so, please unmute yourself.
Hi, colleagues. This is Harire Oneness from UNICEF in Eastern Southern Africa region office. First of all, congratulations for this amazing report and really a lot of data. I mean, the work behind it. But I just was wondering, I mean, as you presented, it shows quite access. Of course, the data is coming from the Western countries and Europe and Americas. The access depth is there. I mean, that's what it shows, the majority of death from the COVID. But just that, in terms of the messaging and also when we control for the age differences. Of course, in sub-Saharan Africa, the age population profile is quite different. So when controlling for that, is their impact really still worse in the Europe, if we say for the same age group? I mean, has that been kind of been controlled for, or have you done that kind of analysis just to say, I mean, you know, the same age group in Africa, but in Europe, the impact, is it still worse in Europe? Is that the message or otherwise? But again, thank you very much for this very interesting report. Over to you.
Yeah, that is a great question. Just to emphasize, in the work we did for World Health Statistics report, this is aggregated data across age, across sex. So for every single country, within the model, we're using the total number of deaths. There are only a few countries where we're able to get age and sex disaggregated mortality data. And as you've rightly put, these are mostly your European countries. So for the work we're doing now with the tag is actually to predict the age and sex disaggregated excess mortality for all countries of the world, including places in Africa, Southeast Asia. And over the months of August, September, we'll be conducting a country consultation where we'll present the methods and the data and the estimates that are used to the countries to discuss the estimates coming from them. The prediction model itself takes into account the socio-demographic characteristics such as historical GDP, fertility and education, but also the age pattern of the population, including the median age at death and proportion over 65. So we are trying to account for age and sex differentials across countries within the prediction, but we have a very wide gap with age and sex disaggregated data for inputs. Over.
Thank you so much. We're already a little bit over time, but I would like still give the chance for somebody else to ask maybe one question or two. If I don't see anything in the chat, but maybe let me ask one final question. I mean, you were saying that there are changes in the causes of deaths, not only due to COVID, but also to other factors. But especially during the pandemic, we have seen, of course, some, let's say, causes like injury went down because people were less on the street, but other causes of death might increase due to COVID because people were not exercising as much, obesity went up and alcohol misuse and so on. Are there already any estimations on the middle and long-term effects of this pandemic and how this will affect life expectancy overall, maybe over the next 10, 20 years?
In terms of the impact of COVID and the other indirect impacts, we've conducted a pulse survey. So the pulse survey was sent out to countries to look at the disruptions to essential services that are related to COVID. So at least for the UHC based indicators, we're able to use some of the results from the pulse survey to look at the impact of COVID. However, for the short-term impact of COVID on, as you said, things like blood pressure or obesity and other indicators, the challenge right now is getting sufficient data. The pandemic has not only affected health, but it's also affected the ability to carry out some of these surveys or to track them. There's some types of services related to HIV, for example, TB, malaria, where there have been disruptions, and those have been quantified, and there's some papers that have been written about the disruptions there. But for some other indicators, really, we are looking, within the future, we need more surveys, we need more data to be able to quantify both the short-term and long-term impacts of COVID. Over.
Thank you so much. So we are now already a couple of minutes over time, so I would like to conclude this meeting, but maybe I can ask all fellow attendees, you can unmute yourself right now, and please turn on your microphones and give our presenters a big round of applause for this report. Thank you. Thank you so much, everyone, for joining today. This is not the last Global Network webinar before everybody goes on vacation, at least in the Northern Hemisphere. We will have another Global Network webinar in 2 weeks from now on the SDG report 2021. So join us again at that time. Thank you, everybody, and stay healthy.
Thank you.